All right, thank you all for being here so early this morning, and I hope I impart some useful information to you. We're going to talk about breast and cervical cancer screening. Let's see. All right, Dylan, my clicker's not working. Okay, no disclosures. So our objectives. I think the current ASCCP, or American Society for Colposcopy and Cervical Pathology, their guidelines are very confusing and there are a lot of algorithms. Instead of trying to have you memorize all the algorithms, my goal today is to help you know where to find them if you need them, and then to follow them in clinical practice. As far as breast screening goes, I'd like you to understand breast screening recommendations for average risk women. And these can be confusing because several different societies have different recommendations. So we're going to start with just outlining the history of cervical cancer screening in the United States, review HPV as a causative agent, and then talk about some of the changes that are going on in the actual screening test. Somebody yesterday asked me a question about cervical cancer screening and time intervals and well woman care, and I'll address that today. As far as average risk screening for mammogram goes, we'll talk a little bit about the history of mammogram. I'll go through some pictures with you. We'll review breast cancer risk factors, and then compare average risk screening guidelines with respect to benefit and harms. So here's my friend again, Georgios Papanikolos, and this is to remind you that cervical cancer still is an important player in the United States, but not as much in the US as worldwide. So the US has one of the lowest cervical cancer rates. India, by comparison, has at least 10 to 20-fold higher rates of cervical cancer and cervical cancer deaths. So this is cervical cancer incidence by rate and ethnicity in the United States. And what you can see here is cervical cancer has been pretty steady for at least the past 15 years in the white population. It's dropped in the African American and Hispanic population steadily. If you look at on the y-axis, the incidence per 100,000 women, it really is still pretty low for all races, and the lines are seeming to converge. This is the Ann Ford timeline for pap smear screening. And we're going to start in the 1900s when cervical cancer was the #1 killer of women in the United States. We go along till about the 1930s when actually 2 men started looking at exfoliated cells for screening for pap smear. That was Papanikolos and another guy named BIRADS. And really, Papanikolos got the credit then for it because he was the one who published the paper that actually outlined the screening recommendations. And that paper was published in 1943. Papanikolos was a pathologist, and he partnered with a gynecologist, and they came up with this kind of way to screen for cervical cancer. So by the 1950s, as we talked about yesterday, this idea of cervical cancer screening annually was becoming very much more routine. And the reason that people had to come back annually is because pap smear screening, although it was dramatic in that it could really help lower the risk of cervical cancer and find it early, it really wasn't a sensitive test. So as such, there were a lot of false negatives, and you had to do it frequently. We rocked along until the 1970s, and gynecologists got complacent. But along comes this idea of HPV as a link to cervical cancer. And it was really a German virologist, Harald Zar Hansen, who was working on this. And this was his life's work. And in 1995, through his work, it was determined that HPV types 16 and 18 were the causative agents of cervical cancer. And the data for this was stronger than for smoking being a causative agent for lung cancer. And as such, in 2008, he won the Nobel Prize for this work. We rock along until the late 1990s when liquid-based pap smears become available. And because this liquid-based test is such a clearer, better test, the interval between screens goes to 3 years. So that actually had been going on in Europe for several years, but in the United States, the idea of the annual visit was so ingrained that it took a while for people to kind of say, no, you don't need your pap smear every year. Part of the reason, in addition to not actually needing the test, was the idea that the test was expensive, and to smear the cells on a slide was really, really cheap. But to put them in this vial that was manufactured with this special preservative and then process it, it made pap smear screening a lot more expensive. So in the early 1950s, you could do a pap smear for $25 versus $250 for a thin prep pap smear today. In 2006, the FDA approves GARDASIL, which is the HPV vaccine, and this is GARDASIL 4. In 2006 to 9, high-risk HPV co-testing becomes available. And the uptake of this co-testing, the idea of doing a thin prep pap smear and then screening the remainder of the liquid for these 12 types of high-risk HPV virus, had kind of a slow uptake, mostly because the pap smear screening interval and who should have it and who should not have it became very confusing. So initially, the high-risk HPV co-testing was developed for helping gynecologists and primary care providers decide what to do with low-grade abnormal pap smears. And my next slide or so will go over that. Eventually, it becomes really standard of care, and in 2012, the ASCCP issued guidelines, and these guidelines were in collaboration with a number of organizations to try to help streamline how practitioners should now perform pap smears, evaluate pap smears, and follow them up with these new screening technologies. In 2014, the FDA approved an HPV-only screen for cervical cancer. So no pap smears anymore initially, just HPV screening. This test goes under the name of Cobras, and it's manufactured by Roche. Does anybody in here use HPV-only screening? No. So in the gynecology world, we don't really use it either, even though it's available. The test itself was developed for HPV-only screening, but it can also be used for co-testing. And part of the reason I think that it hasn't gotten a lot of uptake is it took about 10 years to develop these ASCCP guidelines, and to help practitioners know what to do with this HPV-only recommendation, I think is going to take at least another 10 years. Because you have all these wonderful algorithms, and they're going to have to change everything. So back in 2006, when we were looking at why do HPV subtesting with pap smears, this slide right here in this graph will help us. And it has to do with sensitivity and specificity. If you look along the top line, you can see that the sensitivity of pap screening is really pretty low. If you look at HPV subtyping, it's much higher. The specificity of HPV is actually lower than the specificity of pap screening. But if you take them together, the negative predictive value of a normal pap smear with a negative HPV co-testing screen is greater than 99%. So that makes this a great screening test. So I'm going to go over these ASCCP guidelines a little bit because I think it will help clarify just a little bit. They recommended not to start pap smear screening until age 21. And for women aged 21 to 30, the pap screening interval is every 3 years. And you're only supposed to do cytology. You're not supposed to do co-testing. So for a regular screen from 21 to 30, only cytology. After 30, you can screen with the pap and the high-risk HPV co-testing every 5 years, which is the preferred recommendation, or you can just do a pap smear every 3 years. So in my practice, for people who insist on pap smear screening intervals more frequently than every 5 years, I sometimes do the every 3 years screen. I really try to steer people towards the co-testing just because it's such a good test. And more importantly, they recommended against annual screenings in the general population. And this has been the hardest sell, I think, for the past 5 years. You don't need a pap smear every year. Here's my slide again on high-risk HPV subtypes. And just to reiterate, types 16 and 18 are the most virulent subtypes. 16 is a more virulent player than 18, and worldwide it causes about 60% of all cervical cancers. 18 causes about another 15%. In the way that the manufacturers test for this virus, some of the high-risk HPV tests just screen for all these oncogenic viral subtypes together as just one general screen. Other testing companies actually subtype out the 16 and 18 viruses and then screen the remainder of these viruses as a different test. And that becomes important in if you're able to actually genotype the subtype. So what that means is to determine what subtype of HPV that woman has. And the reason to do that is if they have, and I'll show you the protocols later, but as 16 and 18 as the most virulent subtypes, if you know somebody has that subtype, you may want to more aggressively evaluate the abnormal pap. So at my institution, our lab picked a test that can actually genotype 16, 18, and 45. So when they run the test, and sometimes people don't realize this, the test is run so that actually happens. They just don't report it. So if you want to know the subtype of the virus, you have to order another test, another charge, and then they just report what they already have. Yeah. So I've been talking about the complexity of these ASCCP algorithms on how to evaluate abnormal pap smears. The guideline that I'd leave you with, the general guideline, is after the next few slides, if it's a low-risk pap, I hope you'll be able to figure out what to do next. If anything comes back with a high-grade dysplasia, and you don't do colposcopy in your office yourself, I think you don't really need to know those algorithms per se. You just need to know that that person, regardless of age, needs to be referred for further evaluation and colposcopy. If you want to understand why you're doing what you're doing, I'd recommend this app. It's not free, it costs $9.99, but it's really easy to use. You basically just import the age, the HPV subtype, whether the patient is pregnant, and the initial cytology results, and it'll walk you through the algorithm of what to do. So I just said I wanted to talk to you a little bit about low-risk or low-grade pap smears. And I couldn't do that without bringing up this ALTS trial. And any of you who get pap smears, if you look down at the bottom of the pap smear screening test, they always reference this trial. And this was an NIH-funded trial that was really trying to figure out, back in the late 90s, early 2000s, what we should do with these low-grade abnormal pap smears. So those are LGSIL or atypical cells of undetermined significance. And what this trial did is it broke the cohort down, or the women down, because it was a randomized control trial, into 3 strategies. And basically, you got your pap smear, and you either immediately got colposcopy, they repeated the pap, or they tested you for HPV high-risk viruses. Now, remember, this is when we weren't using co-testing. So this is just in people who came through with pap smears. If you got atypical cells or low-grade cells, you went into one of these 3 categories. And if you were normal, you also went into one of these 3 categories. So it's a really large trial. And the results of this trial really helped kind of determine these guidelines for atypical cells of undetermined significance. And what the trial determined was that the HPV co-testing was the best way to determine who should go on to have more testing. And the trial, the ALTS trial, actually said, with the low-grade abnormals, we should probably still refer those people for colposcopy, so let's just let this trial, the ALTS trial, determine what we do with atypical cells of undetermined significance. And so this is how those algorithms for ASCCP look. And so here's how you manage your patient with atypical cells of undetermined significance. It's okay to just repeat the pap smear again in a year. And if it's negative, then they just go on to routine screening. If it's negative and, if it's positive for something low-grade abnormal or worse, then they should be referred for colposcopy. So I work in Durham in a clinic for uninsured women, and the clinic pays for their own pap smears. And high-risk co-testing is very expensive. It adds another couple of $100 to the cost of the pap. So in that clinic, we follow this algorithm, although it's not the preferred one. The preferred algorithm is to test for HPV, and if it's positive, send them on to colposcopy. And if it's negative, then you repeat it in 3 years, not in 5 years. So in a woman who's over 30 with a normal pap smear and a negative HPV co-testing, the pap smear interval is 5 years. If there's a low-grade abnormality, even if the HPV is negative, the interval turns to 3 years. So this is the ALTS trial. My next few slides, I'm going to go over the algorithms with women with low-grade abnormals. So this is a low-grade abnormal in a over 30-year-old woman, or actually over 24-year-old woman. So your pap smear comes back low-grade, and your HPV is negative. So why did I put the HPV up here now? I put the HPV up here now because most institutions now run HPV subtyping on low-grade pap smears. And although the ALTS trial said, you still will miss some women if you throw out all of them, if you don't colposcope all of them, even if their HPV is negative, the ASCCP actually says that you can go through any of these 2 pathways. The first pathway is a low-grade abnormal with a negative HPV. And they actually say it's okay to repeat it in 1 year. It's acceptable to go to colposcopy. So I think most gynecologists don't follow this. Most gynecologists would just colposcope because that's kind of what we've always done. But the preferred route, according to the ASCCP, but in contradiction to what the ALTS trial said, is to just repeat the co-testing again in a year. And I think the reason for this is because HPV is such a good predictor of high-grade dysplasia. And in the gynecology world, we don't really worry about this low-grade dysplasia because the vast majority of these will clear and go away. What we're really focusing on is high-grade dysplasia because you don't get cervical cancer from low-grade dysplasia. This is actually the group of women who we over-test, who we might harm because their chance of actually getting cervical cancer is so low. If you don't do HPV co-testing, then you should refer these people for colposcopy. And if they have a low-grade abnormal with a positive test, you should colposcope them and refer them. And then the management guidelines down here, for people doing just routine screening, I think the pathway over here, where if they're negative and normal, you repeat it again in a year, and they're normal, then you just go on through this algorithm. If they're abnormal and they have high-grade dysplasia, then you go through a different algorithm path. So remembering all this is really tricky. That's why the app is so helpful. So young women ages 21 to 24 pose a completely different kind of diagnostic and therapeutic model. And that's because we're really trying not to harm these women with excessive testing. So in women aged 21 to 24, their risk of developing cervical cancer over the next 5 to 10 years of their life is really low. Because what we know now is you only get cancer if your HPV persists. And to have cancer, even if the HPV comes and goes, when it goes, your risk goes down again. So it's persistent HPV that causes cervical cancer. And for that to happen, it takes a long time. So squamous cancers related to HPV, it takes 15 to 20 years to develop cervical cancer, a squamous cancer. Adeno or glandular cancers are a little bit different, but the vast majority of cervical cancers are squamous cancers. So in young women, we're trying not to harm them. So if young women come back with a low-grade pap smear, like atypical cells or low-grade SIL, you don't do anything. You just repeat it again in a year. So I get a lot of referrals for young women who have low-grade abnormal pap smears who really should just have another pap smear again the next year. So if they have reflex, and if your lab does or you accidentally order reflex HPV testing and it comes back with a positive subtype, it doesn't change anything in these young women. You still just repeat their pap again in a year. And so HPV subtyping in the 24-year-old woman really doesn't have a whole lot of utility unless you reflex it and it's negative, then they can just go back to routine screening if they have a low-grade abnormal, if your lab does that. And that's this guideline right here. And so in my order set of my EPIC orders, I don't have reflex HPV subtyping for young women on the order. And I would only order it if they were atypical or ASCCP, and if it's negative, they go back in the regular group. If it's positive, I just repeat it again in a year. So if they're low grade and they're young, and you repeat it again in a year, and it comes back low grade again the next year, you just repeat it again. So young women get 2 years to have a normal pap smear or to clear their HPV or to become normal again. So when you're young, your immune system tends to clear the virus better than when you get older. So the HPV in young women within 12 to 18 months oftentimes just clears by itself, especially in those non-vaccinated women. So if you follow along this pathway, so you screen them again in a year. You have to screen them for you want 2 negatives for an abnormal pap before you go back to the regular routine stuff. So down here, you repeat it, and then they're negative for 2 years, and then you go back to screening them every 3 years. If after 12 months they become higher grade abnormal, then you would send them to colposcopy. So you've had 1, 2 years, they're still abnormal, you colpal them. And like I said at the beginning of the talk, if anybody comes back with anything high grade, then I don't think you have to worry about it. If there's something high grade, or atypical cells cannot rule out high grade dysplasia, or they're atypical glandular cells, anything other than LGSIL or ASCCP has to be referred. And you can see down here, high grade colposcopy. So I say that, I'm going to show you a different slide for younger women later. But so what about menopausal women? So in menopausal women, or women over 50, postmenopausal women, they're another category of low-grade abnormal where the guidelines are a little bit different. So in ASCCP negative postmenopausal women who are 65, where the current guidelines say don't stop screening. Anybody over 65 who has 10 years of normal PAPs or 3 HPV normal negative PAPs, those people don't need pap smear screening anymore. So 10 years of normal pap smears or 20 years of normal pap smears following a high-grade abnormal, you can stop screening at age 65, except in the atypical cells with negative HPV co-testing. So in general, ASCCP, atypical cells of undetermined significance, with negative HPV, that group means the PAP was normal. That's how I tell patients. If your HPV is negative, it's like your PAP is normal, except in the 65-year-old and older age group, because a very small number in the studies of these older women actually went on to have high-grade dysplasia. So before you stop screening in somebody who's 65, you want them to have a normal negative PAP. So sometimes you can get caught in a loop here, because in older women who aren't using any vaginal estrogens, sometimes they have a lot of atrophy, and atrophy can be a cause of atypical cells. So I have some patients who persistently have atypical cells with negative HPV subtyping, and in order to stop their screening, you really need to get a normal negative according to the guidelines. So in those women, if they want their pap smear repeated, you're within protocol to repeat those paps again. In the postmenopausal women with the low-grade abnormal pap smears, the guideline or the screening pathway that basically says use the HPV to determine who should be originally repeated or who should be colposcoped also comes into play a little bit more. And in my postmenopausal women with low-grade abnormals and negative HPV, I try to co-test those people in a year. But again, sometimes it's hard to have people follow that and be okay with just a low-grade abnormal pap smear. You wouldn't be wrong in referring them for a colposcopy, but the preferred is to repeat in 1 year. Anybody who's postmenopausal, who has high-risk HPV and a low-grade abnormal pap smear needs to be sent for colposcopy. Okay. So let's talk for a minute about this idea of primary testing with HPV only. So this is my kind of slide on what I think the future may hold for us, just because it's a simpler idea because you don't have to do the pap smear screening anymore. So in primary screening with only HPV, you start out over here. Right here. And the algorithm is determined by whether you're 16 or 18 positive or not. So if you're 16 or 18 positive, and remember when I said the screen actually screens for 16 or 18 and then lumps all those other high risk but lower incidence HPVs into a different category. So your screen comes here. It screens for 16, 18. It screens for all the other 12 risk, high risk subtypes. If the 16, 18 comes back positive, the algorithm says you need colposcopy right away. If the 16, 18 is negative, but you're positive for any of those other 12 risk, high risk subtypes, then you PAP them. And if their PAP is at all abnormal, they get a colpo. If their PAP is normal, they get followed up in 12 months with a PAP smear. So it's kind of the opposite. If their primary screening is negative for all of the high-risk HPV subtypes, you go to this routine screening guideline, and the routine screening guideline is to screen every 3 years with this test. So the other thing that changes with this test is the age of onset of screening changes, because you're only supposed to start screening at 25 years old. So we've lengthened the onset before your first pap smear. So I draw your attention to this slide right here because this slide shows CIN3 and cancer risks after 3 and 5 years of these different screening strategies. So the Kaiser Permanente Northern California group has published extensively on this. So we're really just going to look at this gauge study right here. And you can see there are a lot of women in this study, 1 million women, 30 to 64. In the women who had, and here's HPV and here's cytology. So in the 3-year risk of high-grade dysplasia is less than 1% if your HPV is negative. Your 5-year risk is a little bit higher, but still less than 1%. Your cancer risk is also at 3 years super low, and I don't really know if there's much difference between 0.011 and 0.017. So cancer risk is very, very low. With cytology, you could say that this risk is 10-fold higher, but still, your 3-year risk of high-grade dysplasia with a normal pap smear is actually very, very low. This is a thin prep pap smear. Your 5-year risk of a high-grade dysplasia goes up considerably, but it's still less than 1%. Cancer risk, similarly situated, less than 1%, but much higher than the HPV category. So the conclusion of this paper was a negative high-risk HPV provides greater reassurance of low high-grade dysplasia than a negative cytology result. So I liked this graphic because it kind of helps put in perspective what these little differences mean. So on this graph, you see how much higher let's see. So this is CIN2. So CIN2, CIN3, and cancer. And this comes from the same paper. So it looks really impressive that your risk for cancer over here is so much higher than down here, but the actual numbers are still less than 1%. So the purple line right here is pap screening only, and the gray line is HPV, and here's co-testing. And so co-testing does confer a slight improvement in your risk for cervical cancer. And if you looked at the statistics of this, I mean, your p-value may be high, but not really here. And the actual numbers of patients, the difference between 0.014 and 0.017 is really, really small. So the advocates of the HPV-only test would say, if the test is less expensive and it doesn't cost as much to do the co-testing up front, maybe this is a better screen. But again, it's going to have to come with a complete change in guidelines, which I don't think people are ready to, I don't think the societies are ready to do right now, because it's taken so long to even get providers comfortable with the current ASCCP guidelines. But HPV screening as the initial test is out there. So what does the future of pap smear screening hold? So the idea of HPV only as the initial screen, I think, is there, and I think it's coming. For providers, if you want to do this, you have to be really careful, because your screening test has to be approved for HPV only initial pap screening. And currently there's only one company that's approved in that way. You know, what do you do with false negatives? The chances of having a false negative is really low, and that's why I think the HPV only algorithm initially says to screen at 3 years and not 5 years. And how do you make it be cost effective? And is it gonna, if we could make it cost effective if we made the HPV only testing cheaper than the co-testing, but currently it really isn't that much cheaper. So I'm going to move on to mammogram screening now. And here's some breast cancer statistics. This is the most common cancer among women in the United States, and it's the second leading cause of cancer deaths. We have 250,000 cases a year and 40,000 cancer deaths. This is compared to 4,000 cancer deaths from cervical cancer. So the incidence of breast cancer in the United States has decreased from 1999 to 2007. And a lot of people think this is due to changes in hormone replacement therapy after the Women's Health Initiative trial came out. What are risks for breast cancer? Age, race, weight, breast density, personal and family history, and hormone use. So I'll briefly look at these. Here's your probability of developing breast cancer based on age alone. And if you live to only 49, about 1 in 53 women get breast cancer. As you get older, your risk increases. So the cohort that lives to the 80s and older, your risk is 1 in 8. But as that number, 1 in 8 women will get breast cancer, really means that everybody lives to over 70 years old. So breast cancer by race and cancer deaths by race are interesting. So if you look over here, you can kind of, oops, let me go back. Over here, the lines for white women and African American women kind of converge here. Other races, Asian women and Hispanic women, in general have lower incidences of breast cancer. But in the United States now, the incidence is kind of similar for white and African American women. But if you look over here at cancer deaths, you can see deaths for white women have wait a minute, white women, I gotta look over here. These are white women here that have steadily decreased. Deaths for black women also have decreased, but are much, much higher than the white population here and the overall population. So breast cancer is different in African American women. And in general, African American women, if they're going to get breast cancer, they tend to get it at a younger age, and they have a much higher risk of triple negative breast cancer, which is a more virulent, aggressive form of cancer than white women. So how does weight affect your risk of breast cancer? So in perimenopausal women and postmenopausal women, they tend to have higher estrogen levels because of the fat conversion of cholesterol to estrogen. They also tend to have hyperinsulinemia, and both of these factors increase risks for breast cancer. So here's a report that was published in the New England Journal of Medicine from the International Agency for Research on Cancer Handbook Working Group. And this is a meta-analysis of 1,000 observational studies. I will give you my David Grimes. Watch what you're looking at. But in the postmenopausal group, the relative risk of breast cancer increased 1.1 per 5 BMI units in these women. So, and the increase was also significant for ER-positive breast cancers. So I think that this is a very important, not good, but an important thing to remember. And if you're trying to help people figure out strategies to help them lose weight, especially in people who have a strong family history, I think if you kind of acknowledge that being overweight actually increases your risk of breast cancer, sometimes that can be motivating. So breast density. Breast density is a very confusing topic and idea. And in order to understand density, you have to look at the breast. So density is a ratio of fat to actual glandular tissue. So a breast is considered dense if the glandular tissue here and the fat here, if the ratio of glandular tissue to breast tissue is over 75%. It increases your risk 4 to 5-fold for breast cancer. And I think some of this risk comes from the fact that mammogram screening is prefaced on the idea that in a fatty breast, the beams penetrate better through the fat, and you're looking for things that are white. So the fat comes up black, and the calcifications that you're looking for that could indicate a cancer are white. So the glandular tissue is very white mammographically, and I'll show you some pictures in a minute of what that means and how that kind of makes it a lot more difficult to diagnose breast cancer in women with very, very dense tissue. Estrogen. Higher endogenous estrogens increase your risk for breast cancer. So there's a model called the Gale model. And in the Gale model, you plug in a bunch of risk factors, and it kind of gives you a lifetime risk for breast cancer. And those risk factors are age at menarche, age at first birth, and not age at menopause, but anything that puts you at higher risk for higher estrogen levels increases your overall breast cancer risk. Another way to think about this is aromatase inhibitor therapy works by downregulating estrogen receptors, and it really has been shown to increase survival in breast cancer patients. So I like this slide because it kind of quantitates family history risk. So in those models, the Gale model specifically, it asks for a number of first-degree relatives with breast cancer. So according to these researchers, this is a table on the risk ratios of breast cancer by first-degree relatives with a history of breast cancer. The null is you don't have any relatives with breast cancer. Here, if you have one relative, your risk ratio increases by 1.8. If you have two relatives, 2.9, 3 or more relatives, 3.9. But if you look at these confidence intervals, as you get to three or more first-degree relatives, the confidence intervals get a lot higher. But it makes intuitive sense. The more relatives you have with first-degree relatives with breast cancer, the higher your risks would be. So I put this in here just to kind of say briefly that family history is really important. And if you don't want to do high-risk modeling because it may have implications for screening, just refer those patients to somebody who does. And in general, genetics counselors are really, really good referrals to help you figure out who should be considered high risk. This talk is really for average risk women. I put this slide in here for Jan because he sent me this study. And this is a study from a JAMA working group, and it looked at where primary care providers get their information and whose recommendations do they follow. And basically, more people followed the American College of OBGYN than the American Cancer Society or the U.S. Preventive Services Task Force. So what ACOG says does matter. And they say a lot. There's actually a practice bulletin on breast cancer risk assessment for average risk women. And this next little graphic here comes from the ACOG bulletin. And so here are screening recommendations from different organizations on this axis. And then over here, okay, what do they say? So according to clinical breast exam, ACOG says, yeah, we still want to do clinical breast exams. The U.S. Preventive Services Task Force says there's not sufficient evidence to really evaluate that screening test. American Cancer Society says, the data says doesn't really change much, don't do it. And the NCCN agrees with ACOG. It can't hurt, so why not? Mammographic screening gets a little bit tricky because of some of the things that we're going to look at next. So the American College of OBGYN still says you can start screening at age 40, and then you should screen every year at least by age 50. So they're the American College of OBGYN and the National Comprehensive Cancer Network are the two organizations that think it's okay to screen average risk women at age 40. The U.S. Preventive Services Task Force actually recommends screening for average risk women at age 50, and they say screen every 2 years, biennially. The American Cancer Society, if you look at their recommended screening algorithm, it would be start at age 45 and end at age 54 for annual screening, and then screen every 2 years. So I kind of remember that because it's the opposite, 45, 54, and I think maybe that's why they recommended that, just so that people could remember it. This is kind of the most complicated one because it involves 1 and 2 year intervals. ACOG said keep it simple, every year. And when to stop screening is an important thing to think about too. And basically, when you get to 75, most of these organizations say really evaluate the patient and see if their quality of life and their longevity is going to kind of be impacted by whether or not they have a breast cancer. So I put this slide up here, mostly it's kind of redundant from the previous slide, but the previous slide didn't say anything about clinical breast exam, and the American Cancer Society doesn't recommend clinical breast exam, but it does recommend breast self-awareness. So what's the difference? The difference is young women oftentimes find their own cancers. Self-breast exam guidelines and teaching in several big trials, randomized controlled trials, didn't change breast cancer morbidity or mortality. So that's why the recommendation went away. But young women find their own cancers. So I think the societies couldn't say, don't check yourself. So instead of saying, I'm going to give you this specific way that you're supposed to do your breast exam up and down in rows, outside from the nipple, in the shower, once a month, they said, just kind of know what your own breasts feel like, and if you feel something abnormal, come and see us, which is what self-breast awareness is. So the American Cancer Society does not recommend clinical breast exam. The U.S. Preventive Services Task Force says there's insufficient evidence, and the American College of OBGYN keeps saying, oh, yes, do breast exams. And the cancer organizations, the NCI and the NCCN, continue to recommend clinical breast exam. Okay, so here's that slide again. So self-breast awareness versus self-breast exam. We just talked about this, and you can review it on this slide if you want to. So why all this difference? And the differences come in the benefits and harms trade-off to screening mammograms. So I think in general, this slide summarizes it quite nicely. In 1,000 people screened at age 40, you'll probably prevent about 1 breast cancer, but you'll have about 600 false alarms. About 70 people will get a biopsy, and between 0 and 10 people will have something really bad done to them that they probably didn't need. And as you get older, you can see that the number of breast cancers that you diagnose increases, which makes sense because your breast cancer risk increases as you age. The harms tend to decrease a little bit. The false alarms tend to decrease a little bit. Interestingly, the overall harms, overdiagnosis and overtreatment, kind of stays the same. So this category right here is largely women with ductal carcinoma in situ, or DCIS. And DCIS has a broad spectrum of morbidity and also mortality, and all DCIS is not the same. There are probably a lot of DCISs that are treated that, if left alone, would not have progressed to cancer. So, and that's regardless of age. There's a woman at Duke who is running a trial, a DCIS trial now, to see if we can tease out who should really have treatment and who shouldn't. Okay, radiation risk. Basically, you don't get much radiation from mammogram screening, and it saves lives if you start it at age 40. Right here is why the U.S. Preventive Services Task Force recommended screening at age 50. You can see right here that your risk of dying of breast cancer, your relative risk, is the same whether you're 55 or 65. But in order to prevent 1 cancer death in the younger age group, you had to screen 2/3 more women. So 1,900 women had to be screened in the younger age group, whereas only 1,300 women had to be screened in the older age group. So their recommendation from a population standpoint was, for average risk women, this is too high a harm. When you screen, what do you screen with? You can screen with film, 2D, 3D, and you can use ultrasound too, which is something I didn't mention here. So I'm getting low on time here, so I want to go through these kind of quick to leave some time for questions. Here's the difference in the BIRADS score. So every mammogram has a BIRADS score. And you can see here in this, these are all digital, 2D digital mammograms. This breast is almost entirely fatty, and you can see really clearly. This breast has some fibroglandular tissue, or breast tissue, and there's a little bit of white. All these are negative mammograms. This one is heterogeneously dense. The white gets more. Look at this extremely dense breast tissue. It's very, very hard to see anything in this mammogram. Younger women have denser breasts, and that's another reason why they have higher false positives, false negatives, because it's really hard to screen younger women. So the harms of overdiagnosis are much more in younger women. So this is a mammogram from the 1970s, one of the first mammogram screenings that you could have. And as I go through these slides, you'll kind of see how much clearer they get. These are mammograms, film screen mammograms from 1995. In 2000, this fancy machine right here by GE gave us the first digital mammogram. Those are some of the same pictures of different BIRAD scores that I showed you earlier. So the newest player on the block is this thing called breast tomosynthesis, or 3D mammograms. So 3D mammography uses a very similar machine like this, except the arm rotates. And when it rotates, it projects individual images like this in 10 steps. So it takes like little, I think of it like little CT slices of your breast. And in women with heterogeneously and extremely dense breast tissue, it makes a big difference in how easy it is for the radiologist to actually read the films. So here's a routine digital 2D mammogram in a woman with a heterogeneously dense breast. And where's the cancer? Really hard to see because there's so much white. So here is a tomo. This is, This is the 3D image right here. This is the 2D image. And the cancer is right here. So when you magnify the 3D image, you can see that cancer. And cancers on mammography screening look like little stars. They're stellate, and they pull the tissue into the white. So the U.S. Preventive Services Task Force didn't recommend tomosynthesis because they said there was not enough data to say that it changed breast cancer mortality. And over time, I think that may change, but it'll take time to perform the studies. So the Wall Street Journal published this article, and it summarizes the data here a little bit. 3D mammograms detected 41% more invasive breast cancers, and they did it in women with heterogeneously dense breast tissue. The 3D mammography also decreases the callback rate for women with heterogeneously dense breast tissue. So it decreases the false positive rate in women with extremely and heterogeneously dense breasts. The test is best for people with heterogeneously dense breast tissue. I would be wrong to not mention ultrasound, because in some states it's mandated that women with dense breast tissue have an ultrasound. In the radiology world, they don't like to recommend ultrasound for just routine screening because it has such a high callback and biopsy rate. For 20 people that get an ultrasound, 1 person will get a biopsy. So that's just really, really high. We mentioned when to stop screening. You can see here that breast cancer, the incidence starts to go down, but as you get older, the mortality starts to go up. So that's kind of the rub in terms of when to stop screening. So in summary, I hope I've given you some new information to think about on PAP guidelines. And we all understand that HPV is a causative agent for cervical cancer. Mammogram screening is tricky because it's a kind of balance between risk and benefit and how much your patient is willing to accept. And when you're using the new screening guidelines, you have to use shared decision making, because somebody who says, I don't care, I'll be happy to have a biopsy as long as I know that I don't have cancer, I want to be screened every year, you have guidelines to support that, as opposed to the person who says, I had my first mammogram at 40 and I got this biopsy and I'm so mad that I had this chip in my breast and my mother didn't have breast cancer, why did you make me do this test? So those are people who probably should wait till 50. So I have a few minutes, like 5 minutes for questions. Yeah. Yes? Oh.
Women that have the HPV vaccine, the Gardasil.
So if they were vaccinated before their sexual debut, their chance of being HPV positive, especially if they got the 9-valent vaccine, is very low. If they got the 4-valent vaccine and they're HPV co-testing positive, oftentimes they're infected with one of those less virulent strains of HPV virus. So in general, that's a kind of better kind of HPV to have. So I think since it's possible for them to have HPV, and it's possible for them to have persistent HPV, and that's why the algorithms become important to follow that. Did I answer your question?
So you would just follow that algorithm?
I would
that you
follow.
outlined?
I would follow the algorithms. Yes.
Okay. Well, to what? I'm sorry.
So you can speak in so our webcasters can hear you.
So what do you attribute the decline in death rate in cervical cancer among African American women and Hispanic?
I think it's better screening.
Better screening.
Better screening.
So politics does have consequences. I mean, why they're being better screened? What's the?
I think it's access to care, and now that we know that HPV causes cervical cancer, is it something about African American women that makes them not clear the virus, or Hispanic women not clear the virus, immunologically? I don't know. I don't think we know that. I think in general it may be, but we just don't know yet. Clearance of the virus is really, really important in terms of who's going to get cancer and who's not.
This one more? Do we have one more?
In women who test positive for HPV, do you do anal pap smears on them?
So I do not, and the recommendation is not to do anal pap. There is no recommendation on anal pap smear screening. I have a couple of people in my practice who actually have had high-grade anal dysplasia that I felt on rectovaginal exam. But in those women, when I send them to the colorectal surgeon and they did a wide local excision, I pap those women every year anally. So I think if you have somebody who has a history of high-grade anal disease, you can send an anal pap on them.
Okay, thank you.
Just one.
Yes.
What are your thoughts on thermography?
I think there's not enough data to support that as a screening test right now.
I have a question. Quick question? Can I ask a quick question? Quick question. If someone older has been diagnosed with ductal carcinoma in situ, then they die of something else, nothing was ever done for the ductal carcinoma in situ, it was felt to be just to be watched. Is that a family history of cancer of the breast?
I would say no. So I would say in my opinion, ductal carcinoma in situ is not invasive breast cancer. And so in general, I think we've conditioned women to think that it is, and I think it's a different player, and it's what causes all of these harms, I think, about, and I mean, people have gotten both breasts removed because they have DCIS, and 10 years ago that was happening a lot more than it's happening now. So I think it's different category of disease. Okay, thanks.
Okay, thank you.